This module will be the first of 4 or 5 talks on immunosuppression. We're going to talk about immunosuppression in kidney, heart, and of course liver. Today's talk is about induction, which really pertains mostly to heart. To kidney, of course, because there's so much more experience. Yeah, what? It pertains, in fact, at least to heart. But who knows? Landscape may well change. I expect lots of changes in the future. I expect lots of changes in how we manage induction in kidney, but there is by far the most evidence in kidney, so that's what we're going to talk about today. This will be the worst of the 4 talks by far, because Elizabeth and colleagues are in charge of the next, primarily the next 3. We'll do some of it together. It may be my last talk as a professor, since I probably am retiring this year sometime. Haven't decided exactly when, but it makes me kind of sad after doing thousands of talks over the last 40+ years. But anyway, I can't talk to a nicer group of people than the ones here today. So my apologies for this logo here. The first version of this talk I ever put together was at the Yale-Cambridge Symposium a few years ago. And I've never bothered to change the template, so this sort of lingers on. But these are very handsome logos, so I do love them. It makes me feel so important to be associated with the home of some very famous people over the years.
I like the Cambridge one a little bit.
I do too, I must say. We hope to bring life back into this symposium one of these days. You know, this started because we've had a young Cambridge immunology, transplant immunology symposium for years. And a few years ago, we had the idea of just linking a clinical symposium to the scientific one, the laboratory one. And we did it for a couple of years. It was great the first year, not so well attended the second, and not so well attended the third, but we may bring life back into this, just better advertising. Okay, so let's get started. So kidney transplant induction. So I thought I'd just give just a couple of highlights about the time span of all this stuff. You know, it's 2020, right? And this stuff is only 60 years old. I mean, I'm older than this stuff, although it's older than most of you here in the room besides myself. So the inimitable Bill Goodwin, a urologist at UCLA, first used high-dose steroids in fact, a kidney transplant. 1960, that was the first use of induction therapy in the history of our species. In 1962, you know, the first kidney transplants were done in the 1950s, and the very first successful one was between identical twin brothers. So this was before azathioprine was available. Now that transplant, of course, worked famously, and you know, it's one of the hallmarks in our field, one of the great moments in our field. I don't know if you guys know, but the donor, the brother donor, eventually died of ESRD. Probably a lot of you guys know that. I don't really know the history of that. I think the recipient probably had chronic GN of some sort. I suspect it was a genetic thing, not a problem with wearing out of the contralateral kidney. And then Dr. Starzo, the wild one, when he was in Denver, first used sort of more formal induction in the early 60s. By the way, AZA was first used in 1962. So that'd be the first use of AZA as induction combined with high-dose steroids for liver transplant in 1963. The first use of anti-lymphocyte globulin was again by Starzo, also when he was in Denver. Cyclosporin A was the game changer. So I don't think any of you here, you guys are all young, but when I started here, we were doing quite a few kidneys a year, you know, 30, 40. They were all done by urology. After they were done, the patients were admitted to the medical service, the East Pavilion 10th floor, and Peggy B and I largely took care of them. After the first few years of this. Before that, it was sort of just a mix of people who took care of them. So that's how it was done. And so back in this time period, although cyclosporin had been introduced, we were not using it in the late 70s and early 80s. So we were still using prednisone and AZA with a horrendous rejection rate and graft loss rate. But when cyclosporin A sort of permeated the world, as I think all of you guys know, that was the game changer. So we went from 30, 40% graft loss in kidney the first year to where we are today gradually as improvements came along, we got down to really high 90% graft survival in the current era. And not a lot has changed from this period to now over the past 40 years, although, I mean, there are changes, but the fundamental introduction of a calcineurin was the hallmark. The first use of a monoclonal antibody was famously anti-CD3, OKT3 as we called it. That has disappeared from use because primarily of first dose reactions, and also it's highly immunogenic. So recipients get antibodies to it if you use it long enough. The very first use of a monoclonal, you can do these slides, and I think we have some little, just to catch up with me. The first use of a monoclonal antibody here at Yale was given by me. Well, really, pharmacy did all the work, but but I sat at the patient's bedside. It was actually MOG, Minnesota anti-lymphocyte globulin, on a Sunday. Had my New York Times, had a patient with a rejection that wouldn't get better with steroids, and off we went. He was a great guy, and we gave the MOG over, I don't know, 6 hours. I didn't leave his side. I wasn't sure what was going to happen. These eagles would swoop in and take him away or whatever, but I wasn't taking a chance.
So can I just as an aside, how were you doing biopsies back in the early 80s?
We were doing them, we did them, and we were using the old, I think it was a Klatskin needle. They were huge. They were the size of soda straws. And we didn't do very many. We made diagnoses of rejections. To this day, some centers do this by clinical evidence, often not by biopsies. We're probably right a lot of the times, but we're probably wrong a lot of the times too.
Just in a complete aside,
yes.
There's a really nice documentary that they made on Thomas Strussel called Burden of Genius.
Right.
And they're having viewings. They've had viewings at all the major centers. I try to get.
Do you have the link?
Yeah, I have the link. So I got in touch with them. I wanted us to have a viewing here. They've done it at all the major centers, and it cost $5,000. So I emailed the chief of surgery and the head of the transplant center, and they said that.
We're in Pittsburgh. Oh, they won't release it.
Right. They don't want to pay for it.
Right. Oh, here.
It would cost, but
right.
Everyone who's seen it says it's incredible.
Really? Boy, I must say, I would love to.
It would be very nice if you could get it here.
Yeah, I would love to see it. They'll have to put that down. And
I can email you the link.
Yeah, maybe Rich has some influence as the ASN president. Maybe the AST president. Maybe
he showed it at the ATC last year.
The whole thing.
Yeah.
Mm-hmm. Starzo was clearly one of the great pioneers. He was one of the great clinical pioneers of the last half of the 20th century. And in lockstep with the great immunological pioneers, many of whom won Nobel Prizes. He was brilliant. I didn't know him personally, although I met him at meetings. But people who did know him told me that he really wasn't the world's gift to surgery. He was the world's gift to innovation in surgery. But people often spoke of him as having actually some dread of the operating room. I don't know if that's true. Have you ever heard that before, Danny?
Yeah, I went to medical school in Colorado, so under
Yeah.
very much the
lots of
veil
photographs.
People describe those early days as just literally blood flowing out the operating room and down the hallway, putting blankets up to
I'm glossing. This is
flow.
a gloss. The fact that he used these induction therapy at the Denver VA for liver transplant doesn't say a word about how awful these experiences were, with, as you say, floods of blood, lots of failures, but a man who was who was quick and determined and was unafraid to innovate and take chances and risks.
Didn't give up. I
Yeah,
mean,
he would not give
just
up.
sort of murdering people.
We said the same thing in
didn't give up.
cardiology. Like all the
Yeah.
people who changed like cardiac surgery and cardiology, basically, first of all, I never would get to IRB today, and the guy who revolutionized surgery got fired from serial hospitals.
Yeah.
And scheduled 2 surgeries back to back. The first patient died. He was about to get fired from the second place and just saved the other patient's time. So
yeah.
unfortunately, like that.
Anytime. Yeah, this is so interesting, and you know, there are some very nice books that have been written about the history of organ transplantation that, you know, illuminate some of these sort of backroom stories. But when we give these talks, you know, we talk mostly about success, not about failure. And you know, the truth is that today, right, we're probably in one of our worst periods ever for innovation, with so much regulation and risk aversion. It's really quite a change. So then to finish this little timeline, alemtuzumab, which we're going to talk about quite a bit, was first entered. This was from the Cambridge lab, and thus its trade name, CAMPATH. It was from the Cambridge Experimental Pathology Lab, thus its name. And Peter Friend was a key player there. This was first introduced clinically in '95. And then basiliximab, the first IL-2R inhibitor, interleukin-2R receptor inhibitor, 1995, same year. And then Barry Kahan famously wrote the first paper about mTORs in 1999. So Mark Lorber, who was here, who was in charge of kidney transplant, we didn't do much liver under Mark's reign for about 20 years. He worked with Kahan. And so he was very keen on mTOR. So we went through our own very painful experiences with mTOR before we learned our lesson. Next slide. So the early 19, to get back to your point, Ethan, your question. So when Peggy and I were doing this on the medical side, every recipient received every recipient who was on the deceased donor list received automatically, remember this, Tom, 5 units of packed RBCs. Why? Because Terasaki had published all these papers that people who got blood and 5 units or more seemed to be the cutoff had much better graft survival. Now, you know, in retrospect, he was right. I mean, the data were clear. He didn't make this up. But why? We don't know. It might be that by transfusing so much, we selected out patients who then got very high PRAs and never got transplanted. So if you don't get transplanted, then, you know, that is to say, the ones who did get transplanted did not have high PRAs. So we selected out people who were immunologically favored. That's sort of a cynical view of it. There are other more sophisticated immunological views of why this worked, but it clearly did. So that's what we did. Everyone got 5 units. In fact, we even, how do we do? I can't remember with living donations. We did something crazy with living donations. I think we transfused, because they were obviously ABO compatible, donor to recipient blood. Before we realized that we got some sensitizations in doing that, and we took some people, put them in impossible situations. But for a while, we were even doing that. At transplant, everyone got high-dose steroids, A's at 2 to 3 mg per kilogram. For suspected rejection, we did Doppler allografts. Ken Taylor was here then. Ken was a genius in the early days of ultrasonography. And he wrote some papers that elevated RIs meant we got a vascular rejection. So we would often then treat accordingly. It turned out that our high RIs do not mean you have a vascular rejection, but it took a while to prove that. But that was the view in Ken's in this time period. If we thought someone had a rejection, we sent them off for graft irradiation. I forget the dose. But the idea is that T lymphocytes are quite radiosensitive, and we thought naively that we could just pop them all by external graft irradiation. Didn't work. We gave bolus steroids like we do today. Kidney biopsies often weren't done. I say active Congress as if an active Congress is a positive thing. In retrospect, we now know that there is no such thing as that Congress doesn't act. And then we had an anti-lymphocyte globulin, which was made, it was a proprietary product in Minnesota. Who was the guy in Minnesota, the surgeon? He did a lot of pancreases and kidneys and got into trouble later for the way he handled this product. I'm talking about, maybe it'll come to you. So MOG, we called it, and we use that in resistant cases. Next slide. So in the modern era, that was what we were doing when I was a kid. In the modern era, we can separate kidney immunosuppression into 3 branches, of course. Induction, which I'm going to talk about, given just before or at transplant. Maintenance, which is obviously milder, and getting iteratively milder all the time, whenever we think we can get away with it. And then rescue therapy, which is intense and homeostatically stressful and often intolerable. Next slide. So the Yale policy today, induction therapy, is intraoperative methylprednisolone, 500 mg. We often use alemtuzumab. We're in a distinct minority, and I'll be harping on this today. Alemtuzumab, 30 milligram dose. We use RATG, Thymo pretty often in select patients, and we reserve Simulec for low-risk patients. Our maintenance IS obviously is Cellcept. Next, quick tack. And steroid withdrawal for selected patients. Okay, now across the US though, outside of research studies, the choice of the antibody induction is mostly lymphodepleting, and it's continuing to rise over the course. I'll show you in the next few slides. So lymphocyte depleting antibody from the time I first gave this talk 4 years ago rose to about from 64 to 75%. It's sort of leveling off. Simulec, about the same, dropped a little bit, and no antibody has dropped to about 9%. The choice of antibody varies tremendously. You guys should know this. From institution to institution, it can change from Thursday to Friday. Although not so much now. We've gotten pretty good here, I think, at Yale, and speaking for Yale, at having written policies. And we try to stick to it, which is really great. But in general, over the period of lots of these studies, tremendous variation, and both within and between institutions. And then in recent years, the choice of agent has changed very little. Just a few slides to show you this graphically. This is the annual kidney transplant, annual OPTN data report. The report always lags the actual data by about 2 years. So this is 2013. You can see that T-cell depleting is getting up here to about 70, and none, these colors are pretty similar really, but none came down here to about 12, 13. Next slide. And then now, let's see, this is 2016, published in 2018. You can now see that we're up to 75+% for T-cell depleting. And you can see that none is down to very close to 10. Next slide. And then things are leveling off now. So this is the most recent report, just came out a week ago. This is pretty stable over the past few years for lymphodepleting. IL-2R is around 20%, pretty stable, and none is about 9%. So 91% of kidney transplant patients get T-cell, get an antibody in the US today. There are a lot of agents that have been used over the time period of these past 60 years, but for lymphocyte depleting, let's see, there's Spimo, which is raised in rabbits, and it's polyclonal. There's the Fresenius anti-thymocyte globulin, which is not used very much in the US. I think that's raised against a tumor cell line. Is that right, you guys? And then there's AdGam. I think AdGam is from equine source, and that's hardly ever used, and it's been shown to be inferior. Monoclonal choices are OKT3 withdrawn. Rituximab not used too much, and we use a lot of pretty much of alemtuzumab, which is anti-CD52. And then of course we have immunomodulatory treatment with an antibody that doesn't deplete the lymphocytes, but it changes the way they work. And that's Simulec. Next slide. So the three main reasons for induction, I'll skip that slide. You guys know this, and I don't want to sound like I know more than I do after hearing Joe Kraft and a few of our colleagues. So Thymo. So this is a purified, pasteurized gamma immunoglobulin prepared by immunization of rabbits. So one lot of Thymo, I think, is raised in about 20,000 bunnies. And just a side note is the cost of Thymo today is roughly $50 per milligram. So if you do the arithmetic, we usually give 6 mg per kilogram for kidney over X number of days. It works out to about $10,000, $12,000, and that's just the raw cost. I'm sure that the cost to the insurance company is probably about twice that. Would you guess?
Can be.
Yeah.
That's on the insurance.
Yeah. So something like that. So $15,000 to $20,000. And as another side note, guess how much alemtuzumab costs, which we use a lot here. It's our main antibody here in kidney. Zero. Right. So a lot of these drugs are used off-label, And the manufacturers of alemtuzumab now really are interested in the MS market. And they have long released it to centers who were interested in using it for kidney. Only a few took them up on it. And once those few got established, no one else really was getting the drug. And it's probably very hard if you were at a center that's never used it to get it today. I don't know that, but I would bet it is.
That's correct. It has to be patient specific.
Yeah. So,
You know, batch of it.
so we're kind
The
of,
visiting surgeon who was just here witnessing
Yeah.
our translate, he's like, oh, you guys get Campath? He's very excited.
And actually, we weren't one of the programs who had it.
I know.
We only
I know,
got-
David brought it in.
Grandfathered in.
it's grandfathered in.
So what percent of programs you can go to?
I don't, do you know, Lizzie, how many percent of transplant programs have
You
it?
know, some big ones use it. I would say 10 to 20%.
Yeah, that's kind of what I would guess. It's and it's a drug that's actually being used. I can't show you because the data aren't published in the OBTN annual report, but a lot of observers comment that alemtuzumab is being used less frequently at those centers that do have the privilege of using it. But I don't have those data. Yeah, like that 75% of lymphodepleting. I don't know how much that's AdGam versus Thymo. I mean, Campath versus Thymo. Probably the vast majority is Thymo. Yeah. So this is we're on Thymo. It works by a variety of mechanisms, complement-dependent mechanisms, antibody cross-linking, ADCC, apoptosis. It coats the bloody cells themselves. There's so many epitopes it reacts against that it literally can coat multiple targets on a T cell and just simply block their function by coating them without killing the cell. Next slide. And generally well tolerated. Oh, back, I'm sorry. So this 6 mg per kilogram, we're not going to talk about flavors of how much can be used. There is interest in using less than we use, 6 mg per kilogram, which is our standard induction dose. People have used as little as 3, and there's some nice publications that are very recent showing that in selected patients, that's just fine. But we're sort of more comfortable with the 4.5 to 6. Okay, next slide. Mechanisms of induction. This is a cartoon that gets repeated, but just to show you that the anti-thymocyte globulin, just sort of in this cartoon, applies to everything. Next slide. Yeah, skip all those. Now, alemtuzumab, by contrast, this is a humanized rat immunoglobulin in the subclass 1, anti-CD52 monoclonal antibody. Now, the Campath lab actually has come up, but it hasn't gotten to approval yet, with a fully humanized molecule that has absolutely no mouse rat in it at all. But since CD52 is so widely expressed, this thing kills T cells, B cells, NK cells, monocytes, macrophages, dendritic cells. It really is a pleiotropic bomb. It kills a lot of stuff. There's prompt and sustained T cell lymphopenia. It's definitely more than 12 months in most patients, and in fact can exceed 24 months. And that's true both B cells and T cells. Now B cells are somewhat more resistant, but one of the interesting things about this drug is if you're interested in B cell biology, and people certainly have published this, B cell activating factors, including BAFF, are stimulated after some weeks by this drug. So this is just sort of a hint to you about why I think this is a bad drug to use. And I know that some other people do too, because there may be stimulation of B cells and increased risk of antibody-mediated rejection later. And I'm going to show you some evidence that may be the case. Next slide. And just showing you the cartoon, you can skip this, just CD52 drawn there and Campath killing it. And then finally, the IL-2RA antibodies. So how do they work? Well, as you guys know, when the T cell cascade is activated by antigen-presenting cells, one of the first things that happens is signaling to the nucleus to produce IL-2, and then IL-2 is secreted, and it acts both in an endocrine and a paracrine and an autocrine fashion. So it acts to entrain adjacent nearby T cells in a paracrine fashion, and it works on itself in an autocrine way to stimulate its own division, daughter production, activation, new cell surface protein expression, and so on. So IL-2 is critical. IL-2 and its receptor is critical for early initiation of T cell activation. Now, CD25, the target of these two molecules, is primarily activated by, the way it works is that the receptor for interleukin-2 is a trimer. I think there's the alpha chain, which is the target of this molecule, and there's a beta and maybe a delta or something else. But this chain is inserted as after the T cell sees this cognate antigen, the T cell's activated, and then alpha chains from the CD3, the receptor itself, are transferred to the IL-2 receptor, making it active. So that's the alpha chain. Next slide, or next, yeah. I'll show you this cartoon. So basiliximab is usually given, I think, in 2 doses, 20 milligrams apart, 20 milligrams each, 4 days apart. Next slide. So and you can go to the next slide. It shows this better. One more? Yeah. So this is the activated T cell and a cartoon showing the beta, gamma, and alpha chains of interleukin-2 receptor. The alpha chain is not present in inactivated T cells, but it's inserted upon activation. And this is the target of both Simulect and Zinipax. We were using a lot of Zinipax here at one time, but it's been taken out of production entirely now. No fault to the drug. I don't know. They didn't want to compete, I guess, right? I don't think there's any.
And the dosing schematic.
A little funky, not as so convenient. So Simulect now is to my knowledge, the only IL-2 receptor antagonist. Next slide. It's not lymphodepleting. It simply immunomodulates, if you will, dampens down the activity of the activated T cell. So in theory, you'd like induction therapy to do a lot. You'd like it to cool down ischemia reperfusion injury. You'd like it to cool down innate immunity. We're going to get a talk on innate immunity next year and its role in, yes, of course.
Is there any way to measure the effectiveness of the suppression of IL-2? And second, is there like differences in that T cell response according to age of the patient? Like, are younger people more likely to have a response versus older?
Yeah, so I'm going to talk a little bit about the age strata and the association with risk later. One of the worries about induction therapy in kids is that they often they've not had mono. They do not have protection against EBV, and so there's a great deal of hesitancy in exposing these kids to intense immunosuppression. But as far as the responsiveness across age strata, I've seen nothing to suggest anything other than the fact that we all, at my advanced age, we get diminishing, we get weakened immune responses. But I haven't seen how that might affect no one's measured how these antibodies would affect different age strata.
And you can measure their effectiveness as well?
I'm trying to think how you might do that. I don't know of any way outside the laboratory. I don't know of any way inside the laboratory to do it.
What did you could you do flows on them and see like?
Well, it doesn't lymphodeplete, so you'd have to. You'd have to ask an immunologist that. I've not seen anybody report on it. It's a good question, but probably there's a way to measure a T cell's activity in vitro, but it's not relevant clinically. But again, I'm speculating because I've not seen this in any of the clinical reports.
Like in the kids, the pediatric liver, occasionally we will do some flow studies, but that's more getting at the
We measure growth.
depletion.
We certainly measure depletion with flow, yeah. But as far as whether in fact an activated T cell is effectively dampened, I think that's what you're asking. I don't.
Because right now the way we dose these things, it's kind of like based on random, biopsies and things like that. But it'd be very interesting to see if we can tell how what the activity level of the.
No, I quite agree. In fact, that's really one of the hallmarks of the era that we're in right now in solid organ transplant is we can't measure a damn thing. Really, it's all black box. the translation from lab to, I mean, I'm gonna say things are happening now. I think there's some little hints at stuff like AlloSure and a half dozen other things are hitting us now. But up until now, zero, I think, measurements have proven useful to us. Zero. That is to say, to actually measure whether we're effectively immunosuppressing people. I mean, like, just think about it. Like in kidney transplant, we consider a little bit of BK activation as our best measurement of effective immunosuppression. Now, that's pretty pathetic. Because
It's probably worse than cardiac, right?
You know, a little BK means that, you know, that they're effectively immunosuppressed, but it's not too much. They're not getting into trouble. I mean, I know it sounds ironical and sort of, you know, attempted at humor, but it's kind of true. So anyway, you'd like to do all these things, and I'm going to go into some evidence of how effective these antibodies are in kidney transplant. So next slide. So let's get started. So the KDIGO published a paper in 2009, and this is the Foundation for Induction Therapy in Kidney Transplantation today. And the recommendation to the study group, based on high-level opinion evidence, was that we recommend starting something when you're transplanted, okay? Number two, we recommend including induction therapy with a biological agent as opposed to just high-dose steroids or high-dose AZA or high-dose CNI. And that we feel strongly about that. 1A evidence. 121, we think that that Simulect, if I can just to keep you, rather than tying up my tongue, be the first-line induction therapy. 1B, so moderate level scientific evidence. And we suggest that a lymphodepleting agent be used in high-risk patients. And there it gets dicey because what the heck is a high-risk patient? And that gets down to sort of moderate level opinion and evidence, right? So that's where we were in 2009. Next slide. So what is immunological risk? Well, those guys said these are the things that make you a high risk. If you're young, if you're an antique, if you're African-American, if you're non-Hispanic, the degree of HLA mismatch certainly is important. PRA over 50%, but that's all over the place now. Some people use over 0%, some people use 30, whatever. DGF is certainly a risk factor, but you don't know that till after the fact. Cold ischemic time is certainly a risk factor for doing poorly. In places you want a higher immunological risk, we all agree on that. CMV disease comes weeks later. And weight, but only a single study has shown that weight is an immunological risk factor. So of all these, you know, whatever, well, we kind of, I think, in our seat of the pants way of thinking about this, we consider African-American still. Degree of HLA mismatch, especially DQ and R. High PRA, although I personally have my doubts about this. And it's not on here because they weren't measured regularly in 2009, but donor-specific antibodies. No question about it. Delayed graft function, you don't know ahead of time. Cold ischemic time, yes, but things are kind of already in motion. So we're kind of left with these kind of things. And we would add things like, you know, autoimmune diseases, retransplants, a few other things as high risk. So this isn't very helpful, but this is what these guys published. Next slide. But there are a lot of other factors, and it gets to your question a moment ago about, can you look at the cell? Let me just turn this thing off. So, you know, you'd like to look at the cells if you could. What about the balance of this patient's actual cell repertoire in the T and B cell line? Naive cells and effector and regulators. What's on their cells? I won't go into this, but other than to say that, you know, these are obviously things that you probably get to closer to the heart of what this patient's immunological risk is. We don't have measurements outside the laboratory for any of this stuff. Next slide. Next slide. So I said all these factors undoubtedly have interactions that we can't measure. We have very little knowledge about any of this stuff today. We're still black box medicine. Next slide. But you got to move, right? You got to do something. So, so there's some nice meta-analysis I'm going to talk about, and then a few studies, and we'll finish up. So meta-analysis provide evidence that induction compared to no induction is a good idea. The evidence is poor to non-existent that there's any, and I'm going to emphasize this, poor to non-existent, that a lymphodepleting agent is better than a non-lymphodepleting agent. In my opinion, I may be in a minority, and I wish David Brennan were here because we'd have a lively argument, but that's what I think. Even in high-risk patients, there's no evidence that it makes any difference for hard endpoints. Now, what do I consider hard endpoints? Well, I'm not a transplant recipient, but to me, I'd want my graft to last and I'd want to live a long time. That's what hard endpoints. And if I had a couple rejections and they didn't make me too sick to get them treated, I'd be okay with that. But you know, we can talk about hard endpoints and soft endpoints, but the truth is none of us are transplant recipients, and there's a whole milieu of how you feel about with your treatments and all this and that, your hospitalizations, stuff that we can't get at that are quality of life issues that would make a big difference. But in any event, we can agree that really hard endpoints are death and loss of graft.
When did we used a lot of the non-depleting agents for a long time.
We did, and I'm going to come to that.
Okay.
Yeah, we did. The evidence is really poor that alemtuzumab is any better than anything else. And of course, these agents have their costs. Next slide. So now the Cochrane, Angela Cochrane, who's Australian, and her colleagues who are employed by the Cochrane database, they published a 2004 analysis, a meta-analysis of all the published literature on induction agents. And then in 2010, they updated it. And this strongly influenced Angela's work, strongly influenced the KDIGO stuff I showed you a moment ago. So in the 2010 Redux, they had 71 randomized controlled trials on induction agents, over 10,000 patients. They looked at all languages, and they compared Simulec to placebo, no treatment, or to thymo, basically. Next slide. And this is really where the action is. So we're going to look at 4 outcomes. Graft loss, we're not going to look at death here, unfortunately, but I will in other slides. Graft loss, acute rejection, CMV, and malignancy. Now, if you look at Simulec versus placebo in their comparison, you can see 6 versus 8 in untreated, uninduced patients, events of graft loss. That's a difference of 2. You'd have to treat 42 patients to have 1 saved patient, if you will. Needed to treat is 42. For acute rejection, Simulec versus placebo, Simulec wins. Now the difference is smaller, 9 needed to treat to see a benefit of less rejection. For CMV disease, not such a big influence, actually, and it takes, so actually the CMV disease is actually more common in people who didn't get induced for whatever reason. It takes a lot of patients to see a difference. Malignancy, not significant. Now, what about Simulec versus thymo, which is kind of where we are here at Yale, you might argue. So for graft loss, no difference over any of these, no difference in this accumulated meta-analysis of 10,000 patients, 72 trials. No difference in graft loss. Death isn't on here. IL-2R versus thymo in rejection, well, it looks like the thymo's a little bit better numerically, but it's not statistically significant in acute rejection. Now that isn't true in a lot of one-year studies that I'll show you. CMV disease, it's worse with thymo. Malignancy in this study, it actually is a little bit worse with thymo, but it takes quite a few patients to show it. Okay, now next slide. So we're going to look at a few landmark randomized controlled trials that help define what's done today. The first one is primarily a German trial, but multi-institutional, the Elite Symphony trial. And the primary endpoint was the 1-year GFR. Let's see now. We didn't go past 1, did we? Go back a slide. Okay, go forward a slide. I thought I had the, all right, go back. So in this trial, this was, oh, here it is on top. So the standard therapy that everything else was compared to was no induction. And this is, remember, this is sort of before TAC got around a lot, and this was the only approved drug for transplant. So there's no TAC comparator. That couldn't be the main standard. So it was standard cyclo, no induction, everyone got CellCept-Pred. And the primary endpoint was GFR. Now the comparators were standard dose CSA with Simulec, mTOR with Simulec, or low dose TAC with Simulec. Their low dose TAC is not what we call low dose today. their average levels were about 7 over, followed over years. So it's okay, but it's not super low dose. It's kind of what we call normal dose. Now, they looked at 1-year GFR, and the best group was TAC. So maybe TAC's a better immunosuppressant. I think most of us kind of accept that TAC is the best immunosuppressant. There were less rejections in the TAC group, but the hard endpoint, I keep saying this, graft survival and patient survival, I'm not going to show you that, was not improved by induction. Next slide. And this just shows you that this is just the biopsy-proven rejection rate. You can see that it's less with TAC, but the survival probability of allograft survival is not any different in any of the groups. And the same is true for death. No difference in hard endpoints. So this kind of defined, to get to your point, this was the gold standard around the world for a number of years. Simulect induction, I think we were using Xenopax mostly, followed by TAC, PRED, and CellCept. And in much of the world, that still is the standard for kidney transplantation, although it's certainly changed in many parts of the world. So this is Eckbert's landmark paper, 2007, in the New England Journal. Next slide. Number 2, this is the thymo induction study group. So this is David Brennan's study. Now these were high-risk patients, and they didn't get into the study unless they were higher risk. And I think I show that. It was a multi-institutional trial. You included patients in US and Europe. Pretty good thymo dose, 7.5 mg per kilogram. In fact, in some centers, it was closer to 10. So that's higher than we normally use. So these were, the thymo group was pretty intensively induced. The Simulect dose was pretty standard. All patients had to be high risk. Either they had a high probability of getting VGF, rejection, or other issues. So they had to be that. And then maintenance IS was identical. Cyclo, CellCept, PRED. Because Cyclo is the only drug approved, only CNI approved for transplant, so it had to be used, even though TAC was a little bit available then. Next slide. So the inclusion criteria, I mentioned high risk. Next slide. So the other thing I wanted to show you here was that in the 1-year follow-up of thymo versus Simulect, notice that antibody-treated rejections were less frequent here in the thymo group, 2 versus 11. That was significant. And notice that biopsy-proven, mostly cellular rejections were also less frequent in the thymo group. So rejections less. No one argues that point. I fully agree that thymo's better than anything else in comparisons for acute rejection in 1 year. But death rates, unaffected. Now, what Brennan did was clever. So he had US patients and he had European patients. But there's no way to get data and follow up on European patients, right? And it's expensive to do these studies for more than a year or 2. So what he did was he managed to, by using simply getting licenses to inspect different databases, probably insurance and Medicare databases, to see which patients that were in his study get admitted for rejections. And he was able to get his hands on death certificates and dialysis certificates. So he was able to put together 5-year follow-up on these patients. Next slide. On the US portion. And I'm sorry for the blur, but graft survival in thymo versus Simulect, no difference. Patient survival in the 2 groups, no difference. Now they did this again at 10 years, which is almost unheard of. Next slide. And here in 10 years, he could show a difference, Brennan and colleagues, in the triple endpoint for the thymo group. So if you throw in rejection rates and death rates and graft survival rates for a triple endpoint, you can milk out a significant difference. And I suppose that could mean something. It may explain why he endorses thymo induction so strongly, and why he's the author of the up-to-date section, and that a lot of us clinicians read, and a lot of people are strongly influenced by it. But he just says thymo, don't even consider anything else in standard to high-risk patients. Next slide. So that's based on this is a New England Journal paper. One more, right here, 2006, and it was the thymoglobulin induction study group. Okay.
next one is alemtuzumab. This is the 3C study that was a multi-institutional study from England. And because the theme kind of gets the same, is kind of the same, these patients had alemtuzumab versus basiliximab, Campath versus Simulect comparison. And just to come to the quick end, so there were less, turned out that there were less biopsy-proven acute rejections in Campath versus Simulect. Now, follow-up, long-term follow-up, death rates, graft survival rates, no difference in the 3C study. Next slide. Skip that, next slide. Next slide, that's just a sideline. And the INTACT study, this is Steve Woodle, who's he's pretty aggressive, and he's pretty innovative. So this is his study that was published also in the New England Journal more recently. And this looked at alemtuzumab versus Thymo, okay, so the two big guns in high-risk patients, and alemtuzumab Campath versus Simulect in low-risk patients. So he kind of snuck two studies into one, and everyone was steroid-free, because that's Woodle's trademark, is steroid-free kidney transplant. Next slide. Let's see, right here. So primary endpoint was rejections at 6 and 12 months. So everyone focuses on that because it's expensive to do these studies, and you can't follow patients very long for long-term endpoints, and it's easy to diagnose rejections because everyone's comfortable using 18-gauge needles for many years now to diagnose these rejections. So patients were followed for 3 years, not for secondary endpoints, for safety and efficacy. Next slide. And the main thing I wanted to show you, I think it's on here, was that there were less rejections in the low-risk group only, not the high-risk group, which had Campath versus Thymo. But in the Campath versus Simulect low-risk patients, no surprise, Campath's better, less rejections. What about, survival of patients in grafts? No difference in either high-risk or low-risk across the comparisons. Okay, that's Woodle's study. Keep going. Next slide, please. And lastly, a follow-up to the Symphony trial, also a German trial, the Harmony trial. This is just published a couple of years ago in Lancet. This is important, I think. I'm not going to go into it because it's running out of time, and I don't want to beat the theme to death. But this is important. So in the Symphony trial, I didn't show you the data, but the NODAT risk was really, really high. And it is here too. NODAT risk is what? Danny, would you guess?
Do we have up-to-date data from here?
30%. And that's inclusive of all of our patients, right? So that wouldn't distinguish whether patients were steroid-free, older than 65, just all comers. 30%, right? Diabetes is crazy high frequency around the world. And it's a big deal because what's happened to all of our patients after they're transplanted and they do fine for a few years, you know, they're all getting sick from cardiovascular disease. And they're all, not all, but you know, the death rates are predominantly, kidneys are going down, death with function graft, and people are dying from cardiovascular disease. It's epidemic in this group. It's much higher than most other groups of patients. So what these guys did in the follow-up to the Elite Symphony trial and this Harmony trial, it's very similar, multi-institutional German trial, then these were low-risk patients. So I won't go into the details, but they were very low risk. So they were randomized 1 to 1 to 1. A was the Elite Symphony trial. That was the comparator. That was the standard group. So that would have been TAC, CellSet, PRED, and Simulect induction, which is the worldwide standard in many parts of the world. B was the same as A, except they got steroid withdrawal. Only difference. C was the same as A, only they got Thymo induction rather than Simulect and steroid withdrawal. So B and C, then the main purpose of this study was to see, God, this diabetes is terrible. Can we do something about it? Just take everyone off steroids. I don't care if they're 65, let's take them all off. Now these are low-risk patients. For low risk for rejection. They had fairly low PRAs, they had no DSAs, they ABL compatible, there were no DCD transplants, cold ischemic time. I don't consider 30 hours exactly perfect, but you know, wasn't 40. And so they're fairly low-risk patients. Okay, outcomes. Next slide. I'm only showing you one outcome. Nothing about transplant survival. Look at this. At 12 months, look at the NODAT rates. 40% in A, and steroid withdrawal cut down by about 40%. I think that's remarkable. And we don't talk about this enough.
What dose were they using, you know?
What?
The ongoing steroid doses.
No steroids. These were B and C.
How about the,
Oh, this
So
5 milligrams. Yeah, 5
those are
milligrams.
standard?
Yeah,
dose.
standard, just like we do. But these were steroid withdrawal. So the difference here is that everyone was withdrawn from steroids, unlike what we do here, and you're only withdrawn from steroids if you're, maybe some people less than 65, select patients, but basically over 65. And I think this is personally, I think we can do better than we're doing. Next slide.
Good question. So at least in heart, we think of like African American females as higher risk. Is there like a large percentage of African American people in these trials, or is it mostly like?
Well, they always specify. So now in this German trial that I just showed you, it's like 1 or 2%. So it's a typical European population of Caucasians and fairly homogeneous genetic pool. So that's a problem. And I don't for a moment say that we'd see the same results. I don't know what the diabetes risks are in Western Europe. They're hideously high here in this country, but I don't know if they're as high. They may well be, because they're seeing the same NODAT rates that we are in a population that we would consider sort of at first glance lower risk than ours because they were so white. Next slide. So I think I will not repeat all of that. I'm saying basically that antibody induction is better, no question about it, for preventing rejections. Lymphodepleting is better for preventing rejections, especially in the first year. I don't think you can say anything else much about it, in my opinion. Next slide. Now I've got, keep going. Now I've got about 4 retrospective studies of the OPT and SRTR database. These are huge studies. They have from 10 to 40,000 patients per study. They're done by top people. They all use the latest statistical methods, including propensity analysis. And they look at different induction regimens versus no induction in groups like groups who are, say, retransplants, so they're high risk. People who are say, steroid withdrawal and living donors who would probably be considered low risk, and across different HLA profiles. And basically, all of these things show the same thing that I just showed you in the RCTs. That is that induction therapy reduces the risk of first-year rejection, biopsy-proven rejection, across low and high-risk groups in retrospective studies. So they don't differ in any way. But just like the randomized controlled trials, which are much shorter duration than these retrospective analyses, some of these have mean follow-ups of 7 or 8 years. Just like those, none of these show a benefit for induction of lymphodepletion versus non-lymphodepletion for the 2 endpoints I talked about, death and graft survival. Now, I know there are other endpoints. So if you're getting a lot of rejections because you're not doing lymphodepleting induction, your life may be in some ways pretty miserable. And so I fully grant that. But for our final discussion here, I want to emphasize that. So we're not going to go through all of these slides. I do want to show you, though, if I can pick it out in this quick run through. This is not here. This is risk by DR mismatch. Next slide. If I can find it, I'll show you. This is same study. Next slide. This is Tanriover, who's from Texas. So in a retrospective look at people who were PRED-free, different reduction regimens, Thymo and Campath, again, significantly protect from early rejection, 6 and 12 months. Next slide. But, and this is one of the things I wanted to show you, and Danny, I'd be curious about your opinion about this. In this same study, this is a retrospective analysis of our main database. The long-term graft failure rate is higher in alemtuzumab-treated patients, statistically higher. I wish we could sort of go into this, but trust me, this is replicated in about 3 large retrospective analyses. Next slide. Retransplant patients, same thing. If you look at graft loss, the rank order is worse for alemtuzumab in long-term follow-up. If you look for patient death, the rank loss is worse for alemtuzumab in long-term follow-ups. Next slide. So, same thing I said before, any antibody is better than no antibody. You can't convince me without quality of life data that lymphodepleting antibody is better than non-lymphodepleting antibody. And that statement is true across all the categories we worry about: HLA mismatch, repeat transplants, steroid avoidance protocols, trying to minimize steroids, and patients with high PRAs. Next slide. Next slide. That says the same thing. Next slide. So just a quick sidebar. HIV patients, when I wrote this sentence, there was no agreement about what their best induction should be. There have been some published trials since then that I haven't read. I don't know if anybody of you guys have about preferred induction for HIV positive patients.
But they're not non-conclusive.
Still inconclusive. Brennan says, and I think there's plenty of evidence to support that Caucasian transplants between two haploidentical recipients probably don't need induction at all, but they certainly don't need more than Simulect, and I would say nothing at all. And many people think that people already receiving maintenance IS for a prior organ like a heart who then get a kidney do not need to be induced. In fact, there's some evidence that has been published that induction in that situation, a kidney after heart, that actually people do much worse. But I'm not going to go into that. And I think the last slide, my reflections, our patient mix here at Yale has high comorbidities. I can't prove that, but that's my sense of it. Our patient mix, so that would, all things being considered, would favor immunosuppression, minimalization, and more steroid withdrawal, because our patients have tremendous risk for diabetes, and most of them have it already. Our patient mix has high immunological risk for a host of reasons. We have a high proportion of retransplants on our wait list. That favors more intensive immunosuppression, all things considered. Just two kind of comments. I think we should reconsider the use of alemtuzumab. I don't think it's a slam dunk, but I'm very worried about those those reports of late increased risk of graft loss and of patient death. I'm gonna say across most of the other things we measure, like BK, CNV, this and that, it doesn't seem to be, alemtuzumab doesn't seem to be any different than Thymo. I think the thing that favors its use here is that it's free, which is not,
And easy.
and cheap thing to, and easy. Although there are, you know, you can give, there are ways to make Thymo easier. Like I said,
Not as easy as a
No, one
one-time
dose.
sub-Q injection.
no, that's true. You can't beat that. But still, if one could prove those hints at late graft loss and late patient loss, those higher risks, that easiness would be trumped easily. Of course, we'd all agree on that. But the proof is the main evidence is retrospective.
And it's such dirty data. I have
It's
a hard
retrospective
time.
data. Yeah.
It's retrospective, and it's, you know, because of how people, you know, sort of willy-nilly made decisions about induction therapies, I think it's really hard to say that people were making consistent decisions.
I agree.
And
There's
you're
only one
comparing apples to
RCT that
apples.
has shown this, and that was the 3C trial, and that was by Cambridge, the people who made the drug in the first place. And I didn't emphasize that, but in their 2-year follow-up data for hard endpoints, it was worse with Campath. And I gave this talk to the Cambridge people, actually, and they were sitting there shaking their heads. Yeah, they didn't dispute this, and they have the same worries. And I think we should be using more steroid withdrawal. That's my opinion, a lot more than we do. We should take our younger patients who are low risk and get them the hell off steroids.
We would do that for the greater than 65.
Over 65 only.
So I guess, you know, our Mayo protocol, and we use more Campath than anything. We rarely use Thymo, and we use Simulec for our older, more fragile patients with, you know, malignancy history. And really, Thymo was only restricted for PRA greater than 80. That was the only time we gave Thymo.
Right.
So, but we were very free with steroid withdrawal in combination with Campath.
Right.
But we did not do any steroid withdrawal with Similac patients.
Right.
Because that, as the weaker induction agent, there was less comfort with steroid withdrawal with those patients. But most Campath induction were steroid withdrawal.
What's very clear in the Harmony, and that's a prospective trial, very high quality trial, very clear in the Harmony trial that you can do steroid withdrawal with Similac. However, you do have more rejections. You do not have any increase in graft loss or patient loss. But again, the other things that matter aren't measured. And we people who are in the trenches with these patients, I know it weighs on our minds that we're going to have more admissions. It's going to be a problem in our more fragile patients, more time in nursing homes and short-term rehab. I know it weighs in our minds. But the data do not support, depending on the endpoint you pick, not using steroid withdrawal in Similac patients. That's clear from the Harmony trial. And I encourage people to read this, a very nice trial in Lancet from 2017. I'll finish up on just 2 slides. This is not a liver and heart talk really, because this is the current rate of induction therapy in heart transplants. And you can see nationally it's running about 50%. And I'd love to hear your comments about that before we go any further on induction and what the thinking is in the trenches.
I think we're pretty standard with what's consistent out there right now. About 50% of the nation is doing no induction at all, and then the rest of the 50% is kind of split between basilocimab and globulin. There's
On a case-by-case basis, that's true here as well?
we are actually a standardized basilocimab
Right.
At this point.
from when we have patients that we think are considered very, very high risk.
And what do you consider high risk? What are you using for high risk?
As patients, PRA greater than I think we have.
So PRA and anything else besides
If
PRA?
they have any, if they have any frequent PSAs, but other than that, we are kind of leaning towards basilocimab for all.
Oh, okay.
We've done the other way as well, where we know if we have a patient with significant driveline infections, or if they're time of transplant for whatever reason, we omit induction.
Right. So you're giving 20 milligrams twice across the board. And thymo?
Rarely.
Rare.
This, in fact, more recently, I think we did thymo in our most recent patient, but that's more.
Right. And I might have missed this because I must say I didn't spend a lot of time on heart. Are there any publications that favoring induction versus no induction, or any particular agent, or nothing conclusive?
There's a lot of controversy between it. I think the most recent trial that's looked at globulin versus basilocimab, looking at 1-year outcome data, that they showed no difference in patient survival at 1 year, but they also looked at 5 years as well, and they do associate thymoglobulin with better outcomes in the long run. They also did see higher rates of PTLD, but that's
Okay. And
Like, for example, like the pediatric CAR team went with thymo and never.
the pediatric teams have very clear-cut data for less than 18 years old, that they should be getting thymoglobulin. There were some discussions on if we should extrapolate from that, but I think we do have some decent data with associations with thymoglobulin for long-term outcomes.
Okay. And then lastly, for liver, Dan, if you have any comments about this, by and large, induction has not shown any benefit in liver. I did read the papers that have been published when I first put this slide together. This is the updated slide, and I don't know if there's anything in the last 3 years.
Yeah, I would say there's not great data in liver, period. Anecdotally, when folks have DSA and things, we'll be just as likely to give IVIG or plasmapheresis or do those kinds of things. We also sometimes, like in the pediatric liver, we just maintain people on IVIG if they have high MFI DSAs.
Right.
And then I would say basilocimab really is, and it drives me crazy a little bit, but we give it in our renal sparing protocol to delay TAC.
Right.
I don't really believe in that at all. I don't think there's any data to support that. I think it makes people feel good that they're not giving immunosuppression.
gonna
And
say-
maybe they're doing something, but
Yeah.
I don't know if it's really protective any more
Yeah.
than just the liver is.
There are a lot of
Tolerance.
sidebars for throwing in Simulect or Thymo in both heart and liver to get over rough patches. And those patches usually are trying to get the patient off tack for any of a variety of reasons. I know we've seen a couple of remarkable heart transplant recipients who were experiencing very poor graft function. And I know that I was involved because the patients had severe prerenal azotemia. And in 2 cases that I'm familiar with, we stopped TAC and substituted Thymo for a little bit. And I know one of them, I mean, literally before our eyes, the prerenal azotemia melted away within a day or 2. And then I was talking to the heart team about this because I was astonished. And of course, it was just kind of been a coincidence. But then I was told that there are data that TAC can act as a functional toxin for myocyte function. No one sort of handed me a paper, but this was believed. I was speaking to one of them.
That's the first time I'm hearing about that.
Yeah, and nobody handed me
Maybe
anything.
if I say it, then.
It kind of reminds me about using the 3% saline to treat congestive heart failure. But I guess there are real data there.
It's not very good.
Yeah, yeah. But as far as this functional impairment of myocyte function by TAC, no one
You
could
can find
get
it
any
there
data.
and then show anything.
But anyway, in these 2 cases, we took away the little poison of TAC for a few days.
If you
all remarkable
do
turnaround.
induction, I mean, this is very simple. So where I trained in induction, here we do same thing. That's very similar protocols. Does that imply that you can be less aggressive with starting the calcineurin inhibitors? Because what bangs up the patient the most is renal failure early
Right.
after transplant. So could we just hold off on the DAC for a week or 2?
So that's what we do on liver.
That's a
You know,
reason
if we
in
give
kidney.
Simulect, then we delay initiating TAC until like usually post-op day 3 or 4. And then we start like 1 and 1. But then I would say fairly reliably, we start having a jump in the bilirubin about 2 weeks out when we're still not therapeutic on our TAC. And we have to push the TAC like crazy. And then we're probably having some early rejections that then we just treat with Prograf rescue.
Yeah.
You know, so I'm not, and I'd be interested to hear Liz's thoughts, but I think I feel like we're treating our own fears a lot more than we're really doing something physiologic for the patients.
Yeah, the strongest data with delaying calcineurin inhibitors with induction is in kidney. And the data there with Simulect induction, if you don't have therapeutic TAC levels by day 5, you have increased rates of rejection. And if you, with Thymo, you have a better window of opportunity, but it's still, if you have a non-therapeutic TAC level within probably 2 weeks, you are at increased risk of rejection, even with Thymo induction. But with Simulect, it's still not really buying you much. Now, I would say though, for the heart protocol versus liver's almost not really using Simulect as induction because it's not prior to reperfusion. And you are, in heart, you are giving it prior to reperfusion, right? So, so they're in liver, we're giving it in the ICU after transplant when your true benefit of induction is mute. So
we give steroids at amhepatic phase as our induction.
I mean, one of the worries has been that, secondary lymphoid organs are not exposed to these agents as well. And so you can certainly deplete, circulating B and T lymphocytes with elotuzumab and with Thymo. But what are you doing to the bone marrow, secondary lymphoid organs, and the graft itself? And if you don't have TAC on board, which will enter these organs, by all means, you could, in theory, have T cell activation and get the process going. So,
I mean, there's so many questions that come because it's just so cool that you gave this talk, and there's so much. I mean, a lot of stuff I've been told that I've kind of taken as granted. So, for example, during our meetings, it's someone's getting calcineurin inhibitor toxicity or renal failure. They're like, well, let's just give them basiliximab every or as a immunosuppressant. I mean, I don't know if the data for that.
There's a couple of cases where I actually look at calcineurin
Or like, is the risk, I mean, we assess rejection differently in different organs. Like, is the risk of rejection different in different organs? Like, what's the, like, do you have to be, I mean, more
The innate risk.
or, yeah.
Yeah.
And then in our elderly patients with heart transplant, we almost never see rejection, you know? And like, I don't know why we hit them so hard with like induction and then DAC. I mean, we probably like cause them to, you know, go on dialysis years sooner by like trying to keep their DAC levels at 10.
Right. Well, one of the nice things at a place like this is, you know, we have people coming in who are trained at different centers and have very different points of view. My own view of the kidney program, which I've had the pleasure of, you know, watching now for decades, is that we're conservative, and I feel right now we're in a rather aggressive era of immunosuppression. Earlier on, we tended to lag behind innovative and aggressive centers in aggressiveness. So we were sort of ASA pred forever here, and we were rather slow to start using calcineurins. And then for, you know, life is about particulars. So when this isn't meant to in any way to put him down or be negative about Mark Lorber's tenure here, but Mark liked RAPA. So these individual, and David Mulligan
And David
likes
Campat.
CANPAT, right? So that determines what happens. Publications be damned. Not really. I mean, if these publications were clear. But I think that the data for steroid avoidance is so compelling in a larger subsegment of our patients than we do now, that we should revisit our policy.
And when we brought CANPAT on board, like me and Eric really wanted to go steroid free, but because, you know, our group mostly practiced with not withdrawing steroids, we were really hesitant to do that.
Right.
I mean, I think now that we have internal data for the CANPAT removal,
Right.
I think it's better. But
What's going to be the fate of CANPAT and its manufacturer and their?
Still no endpoint.
Yeah, there was talk a year ago about it being.
There's a talk every year.
Yeah. So nothing really.
Nothing really that it's going on.
Okay.
But I really feel like the data, just in terms of induction and CNI delay, I think it's really with IL-2RAs, it's hard to truly delay CNIs without getting it therapeutic, without having a good window. And then two, I think, you know, we went through an era of T-cell depleting therapies where we would measure, you know, do flow cytometry, measure levels, and then that would determine if we dose, which the data for that is, you know, null, just in terms of your question about.
But what are we calling therapeutic, right? So if you're
Right,
saying like 8 to 10, what are we basing that on? Are we basing that on the effect that we're having on the T cells? Like,
No,
you know,
yeah,
like,
no, you're
I
quite
mean,
right.
I don't want to, you know, this is all friends, but I mean, I think that biopsies, heart biopsies are kind of bogus. Like, it's like, you know, like you're biopsying this random part of the heart, and who knows, like.
Well, there certainly are groups that have published data about maintenance levels of TAC and the risk of graft loss, and interwoven that with compliance, particularly, for example, in Canada. What's it called? The guy that does all this stuff.
John Gill.
No, it's not John. It's a guy, I'm blocking his name, but published a lot on this. And so that's why we keep talking about, I think more recently, in these iterations, these papers come out, we say, oh, we should be running TAC a little bit higher. And we have a belief, for better or for worse, that we didn't have 5 years ago, that TAC levels of 4 are bad for you. That's our current belief. Now, I'm not talking about assay differences. I'm talking about, let's say, the old assay. We didn't believe that, or a lot of us didn't a few years ago. We thought 4, Sanchano felt that way. It's okay. You know, anyway, to finish, I think as we go forward with these talks, I mean, I'm always kind of a dreamer, but I think it'd be nice when we do the immune section to have an annual revisit of our policy across all 3 organs. And the speaker has the responsibility of updating, just, you know, like this is the first talk on, say, induction. So updating anything in the interim, and then we can use this for policy development in our own internal guidelines and making changes.
The other thing we wanted to do was to have each speaker put out at least, say, maybe a maximum of 3 papers in advance of his or her talk. And then the people who come here will have an opportunity to read them for themselves, and then they'll go into our archive. And Sartak here is going to take the lead in keeping that a living force.
You're getting projects like every meeting.
Would you like that for next week's?
We should do a debate. That'd be fun.
Oh yeah, no, I quite agree with you. For some of these controversial topics, we should do indeed a debate. I like that idea too. So anyway, just some random thoughts. So thank you, everyone. It's been fun.